there's still no substitute for the one-time surgery of gastric sleeve or gastric bypass with minimal side effects. It's a better economic value for everybody, and the long-term weight loss is going to be more or less permanent versus taking the drug for the rest of your life.
Thanks for tuning in to Conversations with Betty LaMarr, coming to you live from the Bluff City. And now, your host, Betty LaMarr.
I'm Betty LaMarr. Today we're having a conversation about current trends in the treatments of obesity with the master bariatric surgeon, Dr. Robert Wegner. Welcome to Medical Talk, Dr. Wegner.
Thank you, Betty, for having me back. It's been years we've been doing this, I
Yes.
can't even remember it's been so long.
Yes. Before we jump in, because we need to talk about these trends, so much is going on now with weight loss and the lack of. So tell our viewers who you are as it relates to our topic today.
So I'm the medical director of surgical weight loss at St. Francis Hospital here in Memphis. I've been in Memphis at St. Francis since 2010. This is where I've been my entire career, taking care of patients at St. Francis here in the Mid-South in Memphis and from the surrounding area. We were doing volumes of surgery there, hundreds and hundreds of cases a year. But I still feel like, getting out in the community, doing shows like this with you and others, and through, print ads and whatnot and other interviews to reach more patients. I've been here a long time. I've done, I think over 5,500 cases since I came here. Ooh. But I still feel like there's so much more work to do.
Yes.
Morbid obesity is still rampant in this area. You see it, I see it every day. So I still feel like, there's a lot of work to do, a lot of people to help. Okay. So I'm glad that you have me on this forum to talk about what I do.
Well, you're the master. So when you need to talk about something this serious, you want to go to a master.
Yeah.
Now, you're right. I look around and I have a lot of people to say, we always ask people like, who do I need to bring back? Dr. Wegner, because people feel like, well, we're looking around and do we not have enough bariatric surgeons, or are people just giving up because it seems like there's more and more and more? So what are you all doing?
I don't think people are giving up. I still think there's, as much as I can do, as much as you can do, there's still a lot of misinformation in the general public about weight loss surgery. So when I have a forum to talk about it, the points that I want to get across is the biggest hindrance to getting it or not getting it is still insurance coverage. Oh. Patients have to be more proactive with their employer about getting their bariatric surgery covered, or looking at their plans and making sure that bariatric surgery is a covered benefit. And so every year they need to look at their plan and make sure that if it's in there that they have the correct plan, whether it's a high deductible or low deductible, I'm not sure whichever one it is, but they got to look at their plan and make sure that they have it covered. So I see a lot of patients that come in, they'll have the coverage, then they'll not adjust their plan, and then next year they'll lose it and they won't be eligible. So you have to stay on top of it. But that's still the biggest speed bump for people getting help from me or having surgery is the coverage. Now, if they have the coverage, the second thing that seems to keep patients out is a fear or somehow a misconception that it's dangerous or unwarranted, or it's an easy way out, which it is not. This is still the number one safest, most effective way to treat morbid obesity. Bariatric surgery, gastric bypass, and gastric sleeve are still hands down, percentage-wise, in safety and outcomes and percentage of weight loss. Nothing compares to the result you're going to get from having a bypass or a sleeve. So patients have to, think about that when they're thinking about having weight loss surgery, why they're doing it, can they get it, and then where are they going to go to get it.
Okay, now, since you mentioned insurance, there's just something that I hear a lot that I don't think is fair. I talk to people at a particular, I guess you would call healthcare.
Like a fair or forum.
Hospital. And they want Dr. Robert Wegner to do their procedure. But because they work for a particular hospital, a healthcare institution, whatever you call it, they can't come to you. Why should that matter? Why can't I, as a patient, choose who I want to do my surgery?
So that's what I mean by looking at your plan. Because if, like, let's say it's an employee of another institution or an employer that has a certain plan where you have to go to a certain hospital to have your treatment. So there are plans where you can have, you know, more control over who you see, but there might be a different cost monthly, but that gives you the flexibility to go who you want to go to. So patients need to look at their plan, and when a patient comes to the center at St. Francis, we go over their plan with them. Say, listen, you know, you have to do these certain things to get qualified for surgery. We let them know on the front end if they are qualified to have it at our institution. If they're not, what they need to do to get it. But I see a lot of patients that exactly like you're saying, they want me to do the surgery, but their plan excludes them from the St. Francis system. So we got to tell them, listen, the next time your open enrollment comes for your employer, go to the plan that gives you the flexibility to come to have me do your surgery, which we tell them all the time. And then most of them do that. They'll wait till the following enrollment period and they'll change their plan. So I want to help as many people as can. We have a stack from the floor to the ceiling of patients that either didn't have coverage or were excluded. And then there's the self-pay option, but not everybody has $15,000, $16,000, $20,000 for the surgery. It's still considered a lot of money for most people. So I'd rather have insurance pay for it.
Yes.
And they do cover it. It's just a matter of making sure your plan includes it. So I always tell people, be vocal to your employer, get the plan that covers it, and then if you need us to help guide you into which plan that is, our center is more than helpful, or more than willing to do that.
Okay, now we're going to take a break, and when we come back, Dr. Wegner, I want to go into some of these trends, and it's all over the news now with all this stuff going on out here with people trying to lose weight the easy way. Okay, so we'll be right back. Stay tuned for more medical talk.
For more information about the CAPA program, visit ghscapa.com or call 755-7775. You're watching the award-winning GHS TV, a nationally recognized student television station.
Welcome back to Medical Talk. I'm Betty LaMarr. I'm having a candid conversation regarding the health complications linked to obesity with bariatric surgeon Dr. Robert Wegner. Dr. Wegner, now we're talking about weight loss trends. We all hear about Ozempic. Let's talk about that from a bariatric surgeon's perspective. Are you prescribing it, and if not, why?
Okay, so Ozempic is a trade name for a generic drug that's semaglutide. Okay, it's a GLP-1 agonist. It's been on the market for years. This is not a new drug. It's been around forever. You've heard the ads, Ozempic,
Yes.
blah, blah, blah. So that's the ad. You hear it, kind of sticks in your head.
Yes.
That ad's been around forever, and everybody knows what the drug is. And if you listen to, in the ad on TV, when you listen to, I always have to list the side effects at the end of the ad. There's nausea, vomiting, GI upset, cardiac symptoms. And one of the side effects they say is some patients may experience weight loss. So we've known for years that Ozempic, one of the side effects is weight loss. So people have noticed this, and they're using it for type 2 diabetes, treating type 2 diabetes with the drug because it causes insulin sensitivity, which makes a type 2 diabetic stabilize their blood sugar. But one of the side effects is weight loss. So suddenly we get the bright idea, well, what if we just give it to people for weight loss, even if they don't have type 2 diabetes? Okay, so now it's not indicated for that. It's off-label. So insurance won't pay for it. So they came out with another drug by a trade name, I think it's Wegovy, that is indicated for weight loss, but it's the same drug. So if they're going to try to get Ozempic, it's not going to be covered. It's about $1,000 a month.
Ooh, my God.
So if you're looking at over time, it'd be $12,000 a year versus a one-time sleeve surgery is $20,000 cash pay. So I don't think, from an economic standpoint, taking this drug long term is going to be in anybody's best interest. Not to mention the fact that you take a drug, every drug has a side effect. And I would say, and the research shows that about 70 to 75% of patients that take Ozempic or this drug, semaglutide, have some significant GI tract upset, nausea, vomiting, diarrhea, constipation, something with the GI tract. It also has some cardiac side effects and some psychiatric side effects. And weight loss is one of the side effects. But they've done studies where they've compared semaglutide to gastric sleeve. And gastric sleeve isn't even as good as gastric bypass, but they use the sleeve, I think, because of the popularity of the sleeve. So they're looking at these drugs versus bariatric surgery, and they come up in a way that is half, if not a quarter, as much weight loss as a sleeve would give you. So if you're going to lose 20 or 30 pounds with the drug, the sleeve is going to provide 60 to 80 pounds of weight loss. Mm-hmm. So it's roughly under half of the weight loss. You still have the side effects of the drug. The problem is when you come off the drug, the weight's going to come back.
Oh.
So that's the catch. There's still no substitute for the one-time surgery of gastric sleeve or gastric bypass with minimal side effects. It's a better economic value for everybody, and the long-term weight loss is going to be more or less permanent versus taking the drug for the rest of your life. So I'm not saying the drug doesn't work or it doesn't have its place for that amount of weight loss. If you're looking to lose 10, 20 pounds, I would say that the drug semaglutide is a good place to start. But you're not going to lose 110 or 120 or 200 pounds with this drug. There's still no drug on the market that gives anywhere near the percentage of weight loss that bariatric surgery gives. So hands down, the surgical patient is not the medical patient. So that's what I tell people. When my patients come into me, they say, well, what about this new drug? I've been hearing on the news, the celebrities are buying it up, left and right. You can't hardly get it. And I said, well, that's fine. First of all, they can afford it. Yeah. And they only need to lose 10 or 20 pounds. These celebrities don't need to lose 100, 200 pounds. Okay, their life is not in danger from their morbid obesity like yours is. Okay. So this is trendy stuff. It's catchy in the news. It's all over the internet. I see the ads and I see people talking about it. It's been on the local news and it's on the national news, and it's even made its way into like some of the stock market shows that I watch, because these drug companies could stand to make a huge windfall from marketing these drugs for weight loss. Why? Because a third of the country, if not half the country, needs to lose weight. So they see the financial benefit of marketing this drug to those people. But that's not going to cure the morbid obesity aspect as far as if you're 100 or more pounds overweight. Surgery is still the safest, most efficacious thing you can do to lose that kind of weight. Okay,
so the word morbid, when you say morbid obesity,
yes,
what makes obesity morbid?
So when your BMI jumps from 35 to 40 and 40 and over, you're now in the morbid obesity category.
What does morbid really mean as far as the...
Life-threatening.
Oh, that's what okay.
So when something is morbid, that's bad. Okay, it's bad for you. There's a life-threatening component to it. It's life-altering and life-hindering. So morbid obesity, is what I'm treating. The obese patient, obesity starts at a BMI, like around 30. There's mild, moderate, and morbid. So when you get over 35, you become a surgical candidate.
Okay.
Surgery is the first-line treatment, not drugs, and not lifestyle changes, and not diet and exercise. Not that those aren't components that you're still going to explore as an adjunct, but surgery is now the number one treatment. So that should be the crux of the treatment at that BMI. So 35 to 40, and then 40 and up. My average BMI for my patients is probably around 50 to 55. So most of my patients, say on average, are between 100 and 150 pounds overweight. And so when they come into the office, and they ask me about a drug or this gastric, the other thing is the gastric balloon. What about the balloon? And we've talked about this before. I mean, the balloon is fantastic. If you're
For a wedding.
Like I said, if you're a Germantown housewife and your wedding's and your daughter's getting married in 6 months and you want to lose 20 pounds to fit into your dress, go and get the balloon, because that's what it's going to help you do.
Okay.
You're going to lose, 15, 20 pounds. It's going to take about 6 months to do it. You're going to fit into the dress, and then when the wedding's over, you're going to get your balloon removed, and you're going to gain back your 20 pounds. I mean, I hate to joke about it, but that's kind of the story that I use. The balloon is a temporary thing. It's minimal weight loss, and it's just meant to be a volume expander in your stomach to kind of give you that kickstart. But it's not a
temporary fix.
Yes, it's not a long-term fix for morbid obesity.
Okay.
And so I've done several patients that have had the balloon. They're like, Dr. Wegner, I wasted $8,000, $10,000 in this thing. I lost 20 pounds. I regained 30, and now I'm ready for my gastric bypass.
Okay, now speaking of gastric bypass, we'll be right back because we want to go into the surgery.
Sure.
I have a question. Watch this space for more medical talk with my very special guest, Dr. Robert Wegner.
Hi, I'm Angelica reporting live from LaMarr Productions in East Memphis. Thanks for watching Let's Talk with Betty LaMarr. Betty is renowned for her successful medical talk show, and now you're invited to watch the space for her new production, Let's Talk, which is laser focused on issues affecting young girls and women in the community. Now, back to Let's Talk with your host, Betty LaMarr.
I'm Betty LaMarr with my special guest, Dr. Robert Wegner. Now, Dr. Wegner, so far so good. The show is wonderful, and as always, I learned so much. Now, let's go into the surgeries. If you will, just break down the different surgeries that you do.
So I perform two primary bariatric procedures, the gastric bypass and the gastric sleeve. The similarities between the two, whereas in they're identical, is the incisions on the outside of the body are the same for both surgeries.
Okay.
They both take roughly 45 minutes to complete. You're in the hospital one night after the surgery. Most patients go home the next day. And the recovery from both surgeries is roughly a week to 10 days.
Okay.
Just take it easy at home, normal daily activity, no straining, no heavy lifting, just kind of common sense. So and the diet, the post-operative progression of food and vitamins is identical for both surgeries. So patients come in, that's like, listen, what's the difference between the two? Mm-hmm. Well, there's more similarities than differences from the patient standpoint. In other words, if I did a sleeve or a bypass on the patient and I asked them on day one, which surgery did I do? They couldn't tell me. They feel the same, they look the same on the outside, everything's the same as far as post-op care and pre-op getting ready. The only difference between the two surgeries is what I do while the patient's asleep. So the gastric sleeve surgery only involves the stomach. So I'm going to go in laparoscopically with small incisions and say the stomach is shaped, kind of like, an odd-shaped football. When I'm done operating on the stomach, it's going to look like a banana.
Okay.
So I'm going to remove most of the stomach, take it out of the body, and it's completely gone. So you're left with a thin sleeve of gastric tissue.
Therefore,
that's why I call it gastric sleeve.
Okay.
Now, so that procedure only involves the stomach. I don't do any alteration to the small intestine. It's strictly working on the stomach, and then that's it. The gastric bypass, on the other hand, involves making the stomach smaller, say like the size of a tennis ball, which is where your food's going to go. But I go down into the intestinal area, say 30 to 50 centimeters, and I bring up a piece of intestine and I sew it to that small tennis ball.
Okay.
The majority of the stomach is still there. I don't remove it, but
Okay.
it's bypassed, hence the name
That's
gastric
a
bypass.
bypass.
So
Okay.
most of the stomach is bypassed, and then a portion of the intestine is also bypassed. The portion that I bring up and sew to the tennis ball, that extra portion of intestine is bypassed. So the sleeve only involves working on the stomach, and the bypass involves the stomach and the intestine. So both procedures, one of the key components is restriction. So you won't be able to eat as much with a sleeve or a bypass. The stomach reservoir where your food and drink go the volume of that's just going to be smaller. So you won't be able to eat as much as you do now. And then both surgeries provide, the sleeve, not as much as the bypass, but a hormonal impact on hunger, satiety, and metabolism, which are the three things that kind of control obesity in the human body. So I can alter, number one, how much food you're eating, and also when you're eating the food, your hunger drive, how you feel after you eat, and then the metabolism of the food when it's in your body. So that's why the procedures are by far and away so much more effective than anything else that's out there.
Question. So why would I choose one over the other if they're going to do the same thing? Why would I want half of my stomach taken away if the gastric bypass would do the same thing without taking away anything?
So when I'm talking to patients about which surgery to get, okay, so I want to know, what's their thought process, what are their goals. Things that I'm looking at from a surgical standpoint is what surgeries have they had previous to this surgery? Have they had a lot of abdominal surgery? Do they have a lot of scar tissue? Do they have a lot of incisional sites from other surgeries? That's going to affect what I can do. Also, how much weight do they want to lose? And what are their comorbidities? Do they have acid reflux, type 2 diabetes? Do they have sleep apnea? Do they have hypercholesterolemia? What are the things that I'm trying to cure for them? So, if they have really bad acid reflux and we do an upper GI study and they have a lot of reflux, sleeve versus bypass, we can discuss, which one may or may not be better. Type 2 diabetics may do better with a gastric bypass versus a sleeve. Sometimes the medications they take, that they have to take, influences which surgery I can do.
Wow.
So you have to look at the whole global patient, figure out the goals, what they're expecting out of it, how much weight they want to lose, previous surgeries, medications they take, comorbidities, and you kind of put it all together, and then you discuss it with the patient, and then we come up with a plan.
Okay, before we run out of time, someone want me to ask you this question. Say this person had the sleeve and lost a lot of weight, lifestyle change, decided to gain weight again. What is the downside for regaining all your weight? To me, other than, you went through all this surgery, why do you want to go backwards? Right. So what's the downside to that?
So with either surgery, sleeve or bypass, the lifestyle changes that we teach the patient post-operative, food choices, portion control, take your vitamins, certain ways of eating, when to eat, what not to eat, how to eat, increased chewing, just techniques of food consumption to be more beneficial, so you get the most out of the surgery. So and I would say 99% of the patients do great post-op, because it does take time and effort, and a lot of thought goes into getting this. This isn't just like you come in Monday and then get surgery Tuesday. It takes months to get the surgery. So they're committed, and they've gone through all the evaluations and everything, and so I think once they get the surgery, the patients do well. But there are patients here and there that lose weight, and suddenly after a year or two, they start to regain.
Okay, now, I got a 30-second wrap here, but I want, and you can always come back, right, because you are the master. Give our viewers your email address, anything that they need, if they need to get in touch with Dr. Robert Wegner.
I would say the best way to get in touch with me is to go on the St. Francis Hospital or St. Francis Center for Surgical Weight Loss website, and there's applications on there to get into the program. There's informational videos about me and patients and the staff and the process of how to get started. And if they want to leave a message for me or any of the staff, they can do it through the Weight Loss Center website.
Well, I would like to thank you so much for being my guest today, Dr. Robert Wegner.
Thank you for having me.